And thank all of you for being here. This is an extremely interesting subject on a very important subject as well. I'm going to start with you, Dr. Pedley. And by the way, Mr. Chairman, she is a doctor. She has a PharmD degree, so as well as being a captain. And I want to ask you, I know that Dr. Draper mentioned earlier when she was asked a question about what could we do to improve the program, she mentioned about the hospital eligibility. But one thing that I'm concerned about is about the patient eligibility. If I've heard you, Dr. Pedley, say once, I've heard you say it 50 times during this hearing, the statute is silent, the statute is silent. What do we need to do to clarify patient eligibility? Do we need to do it legislatively, or can you do it?
So the statute is silent on what entities do with their savings. It does, however, mention that it has to go to a patient, and HRSA does have authority related to creating guidance on who is an eligible patient. And we have done that. We have a guidance currently on what defines a patient from 1996, and we proposed in 2015 additional guidelines related to the definition of a patient. However, we do not have regulatory authority to regulate on what a patient.
That comes from Congress, so we need to do that?
We would need a legislative change.
Okay, count on it. I want to go to you, Dr. Draper, because something is very important to me, and that is, and I know that Representative Collins mentioned this, and it's just something that I want to get clarified here, because I think that there's a lot more that goes on here than we recognize, a lot more ramifications, if you will, and that is the GAO's released a number of reports, including a report in 2015, in June of 2015, that said the financial incentive to maximize Medicare revenues through the prescribing of more or more expensive drugs at 340B hospitals also raises concerns. You acknowledge that. You acknowledge that you have seen a tendency for more expensive drugs to be used, for more 340B drugs to be used in those hospitals that are eligible for this. Not only does excess spending on Part B drugs increase the burden on both taxpayers and beneficiaries who finance the program through their premiums, it also has a direct financial effect on beneficiaries who are responsible for 20% of the Medicare payment for their Part B drugs. This is something that's very important. Throughout this hearing, I've heard, well, this isn't really talking about prescription drug costs. Well, it is really talking about prescription drug costs, because I can assure you this is helping to increase prescription drug costs. One of the things that you were asked by Representative Collins is about the incentive for hospitals to buy up physician practices in order to gain that authority, or in order to gain that ability to have them participate in the 340B program. Is that something that you see happening?
Well, in our 2015 work, we did find that the average number of, I know there's been a lot of discussion about oncology practices in particular, but the number of oncology patients increased for all hospital groups, but the most for 340B.
Absolutely. And the less competition we have within the healthcare system, the higher the prices are. So it's just a merry-go-round here. You know, this is, I'm not naive enough to believe that this is the worst administered program that we have in the federal government, but I think it's an example of how a program that was set out with the best of intentions can mushroom into a program that is just out of control. It's not just the pharmaceutical manufacturers who aren't making as much money as they will. If I have insurance and I'm being charged through the 340B program, the hospital's making money off of me, they're making money off my insurance, they're causing me to have higher premiums in the end. It has just as much an impact on me as it has on anyone. Even though I have insurance, it's causing insurance to go up. It's causing prescription drug prices to go up. Hospitals are right when they say we're in compliance. They're in compliance because what is compliance? Nobody can really define what compliance is. They can point to just about any program that they have, and many of them have fine programs that they're administering. But until we clarify, until we make sure that we are setting the record straight on what they're supposed to be doing with this, no one's going to be out of compliance. Not only that, but the repercussions when we do find someone who is out of compliance, they aren't even there. There aren't even any penalties there. You've said that over and over again. You know, there's one word that we can sum up prescription drug pricing, that we can sum up this program with, and that's transparency. We need transparency within prescription drug pricing. We need it here. We need it in the individual markets. Transparency. Whatever happened to the ability to just buy directly from the pharmaceutical manufacturer? Right now, there's got to be all kind of discounts, and I apologize for getting on a soapbox here, but I'm telling you, it's out of control. Until we have transparency, we're never going to get this under control. This program is a good program, but it lacks clarity, and it lacks oversight, and we've got to do something about it. Mr. Chairman, I yield back.
Gentleman from Virginia for 5 minutes.
Thank you very much, Mr. Chairman. Thank you all for being here today to testify. Let me start with Ms. Draper. And by the way, it's always nice to have you here, and I always love it when I see the Medical College of Virginia listed in your bio. Great school, yes, ma'am. The DISH metric for qualifying DISH hospitals is an inpatient measurement, yet 340B is for outpatient drugs. So does it make sense for us to use an inpatient metric for an outpatient program?
Well, we do believe that that's one of the weaknesses of the DISH measure. The other is that the formula is based on covered patients, and that would be those covered by Medicare and Medicaid. So, there are weaknesses inherent in that measure.
That's just another one of the many things that many stones y'all have turned over and said, whoops, we can't see anything there. Mm-hmm. Yeah. And what is the DISH threshold? Do you know?
Well, it ranges for different hospital types. For some hospitals, it's 8%, the DISH adjustment, and for others, like the general DISH hospitals, it's 11.75%. So that is another issue of whether or not that's an appropriate level or not. And again, that's been pretty consistent over time with the program. So, whether that needs to be reassessed, that would also be a question.
Yes, ma'am. Thank you so much. Captain Pedley, earlier Ms. Draper referenced that prior to the shift or the change, there were 1,300, and if I get the numbers wrong, y'all correct me, 1,300 contract pharmacies with the various entities or hospitals, and now there are 19,000, if I wrote it down correctly when you said that earlier. I got all kinds of complicated questions on that I've been given, but why the great expansion in the number of contract pharmacies? Is it just because we lifted the cap of one, or how did that happen?
The 340B statute is silent on how these covered entities dispense and get these drugs to their patients. We had understood that through state law, entities were contracting with pharmacies. So in recognition of that, we did develop guidance in 2010 that stated if they were going to have these contract pharmacies, they needed to ensure they were also complying with the statutory requirements of diversion and duplicate discounts. And we audit that information on those contract pharmacies when we go in to audit a covered entity.
All right, I'm going to get to that in a second, but I've also heard that the contract pharmacies are not only allowed to charge a dispensing fee, but some of them ask for part of the savings on the drug. Is that correct or is that incorrect?
I don't have the information on that. That's a business matter between the parties and
but it's not prohibited.
Their contract. It is not prohibited.
Okay. Now, let's get back to the audits. You've asked the hospitals to do the audits of the contracting pharmacies. When you go in and you check on those, obviously you don't have enough people to check on 19,000 individual contracts with the various providers to the various entities. So have you uncovered problems? And if you do you suspend somebody? Do you suspend a pharmacy, or do you suspend the entity if they're not doing the proper oversight of the contracting pharmacies?
So we've audited now over 800 covered entities, but it doesn't stop there. We also do conduct the audits within those of their contract pharmacies. So we've audited over 18,000 contract pharmacy arrangements related to those audits. We do ensure that the covered entity is providing oversight. We sample 340B drugs dispensed from those pharmacies to ensure that they have not been diverted or have a duplicate discount. And if we do find the entity is not providing oversight of those contract pharmacies, we'll remove the pharmacies from the program.
All right, now that raises an interesting issue. If you've done the audits and you've touched on 18,000 contract pharmacies, those audits didn't reveal to you if some of them were getting a split of the savings with the entity?
That's a matter outside of our authority, so we don't review it when we audit them.
Okay. Would you like to have that authority? I mean, as long as we're going in to look at this and it looks like it's a bipartisan way, should we give you that authority as well?
We would be happy to work with Congress on a specific proposal.
I appreciate that very much. Yes, ma'am. All right. I might be the last one up. I've got about 40 seconds left. Anybody have something that they really want?
I do.
I yield to the gentleman from Georgia. Oh, okay. I'll yield to the gentleman from Georgia, though.
Dr. Pedley, I just want to make sure and understand, most of the problems that you see, are they with the contracting pharmacies? Is it not true that most of the hospitals dispense these medications that are covered under 340B through their own pharmacies, through their own providers, especially with oncology? I mean, they dispense them out of the office.
It's a combination of their in-house pharmacy and whether they contract with pharmacies. I think, as you mentioned, it also depends on the types of drugs, but it is a combination of both.
Thank you. I yield back.
I yield back to myself. Okay.